Welcome to Obesity Chronicles, a novel perspective. My name is Robert Kushner, and I'm a professor of medicine and medical education at Northwestern University Feinberg School of Medicine and director of the Center for Lifestyle Medicine at Northwestern Medicine in Chicago. This program is intended for healthcare professionals. The information presented in this podcast is aligned with the views and opinions of the speakers and is sponsored by Novo Nordisk. The speakers have been compensated by Novo Nordisk for their participation in this program. The podcast is not to be used as medical advice and is intended for educational purposes only. It is not approved for continuing medical education credits. In today's podcast titled A Story of Two Diseases, Obesity and CVD, we will review the relationship between obesity and cardiovascular disease and how to help educate our patients with obesity about their cardiovascular risk. I am pleased to be joined today by Dr. Michael Blaha. Mike, would you please introduce yourself to our audience?
Yeah, of course. Thanks. I'm Michael Blaha. I'm professor of medicine and epidemiology and director of clinical research at the Johns Hopkins Ciccarone Center for the Prevention of Cardiovascular Disease. In addition, I'm director of the Cardiometabolic Clinic here at Johns Hopkins in Baltimore.
Thanks, Mike. In this episode, we will discuss the growing obesity epidemic and the health costs of obesity with a focus on cardiovascular disease, residual cardiovascular risk in patients with obesity, and the urgent need to address this risk. Let's get started. In the United States, adult obesity rates have been steadily increasing since 1990 and are projected to continue to increase into the future. A study that looked at data of more than 6 million adults predicted that by 2030, nearly half of the U.S. adult population is expected to have obesity, defined as an excess accumulation of adipose tissue that may impair health. Its presence can be estimated by a body mass index, or BMI, of 30 kilograms per meter squared or greater in many populations. So let's think for a moment. If we don't get something done about this epidemic, by 2030, it is projected that approximately every other adult in the U.S. will have obesity. It's important to note that the increasing prevalence of obesity is not just a number or a statistic. Let's take a step back to appreciate what these numbers actually mean. Obesity is a chronic progressive disease that has a serious impact on health and should be treated as such. Obesity is not simply the result of a lack of willpower or discipline alone. It is a complex multifactorial disease, the interplay of various internal and external factors that can generally be classified as environmental, also referred to as social determinants of health, genetic and physiological, and they can contribute to the development of obesity. Now, the good news is, I think that many healthcare professionals now accept that obesity is a disease, especially as we understand more about its biology and pathophysiology. However, there is a lag in the general perception of the public and the media in accepting obesity as a disease. Obesity is still often thought of as a personal problem that one can simply solve with more determination and more motivation, and that is not entirely true. Not only does obesity meet the definition of a disease, but obesity itself can increase the risk of other diseases. Mike, can you talk to us a little bit more about the health costs of obesity?
Yeah, sure. For one thing, we know that obesity can lead to cardiovascular risk factors like hypertension, dyslipidemia, and type 2 diabetes. Obesity can also independently contribute to atherosclerotic cardiovascular disease, such as heart attack and stroke, as well as heart failure, atrial fibrillation, and certain cardiovascular-related disorders, such as sleep apnea. And the health cost for those living with obesity and other chronic diseases is significant. A study reported that healthy life years lost can be 2 to 4 times greater than the total life years lost in patients with obesity living with other cardiometabolic conditions, compared to those with obesity without those other chronic conditions. Not only that, increasing severity of obesity, defined as increased BMI, has been associated with increased risk of cardiometabolic multimorbidity, as shown in a pooled analysis of individual-level data from 16 cohort studies in the United States and Europe. In this study, cardiometabolic multimorbidity was defined as the coexistence of two or more cardiometabolic diseases such as type 2 diabetes, coronary heart disease, and stroke. The analysis included nearly 121,000 adults aged 35 years or older with data available for BMI, type 2 diabetes, coronary heart disease, and stroke at baseline and in follow-up. Patients with type 2 diabetes, coronary heart disease, or stroke at or before study baseline were excluded. During a mean follow-up of 10.7 years, the incidence rate of cardiometabolic multimorbidity steadily increased as weight increased. 0.7% for people with healthy weight, 1.7% for people with overweight, 3.8% for people with class 1 obesity, and 8.7% for people with class 2 or class 3 obesity or severe obesity. And then, after adjusting for lifestyle factors relative to individuals with healthy weight, the risk for cardiometabolic multimorbidity was significantly increased for those with overweight and obesity. Compared to those with healthy weight, the risk of cardiometabolic multimorbidity doubled for those with overweight and increased 4.5 times for those with obesity with a BMI of 30 to 34.9. For those with severe obesity, defined as BMI of 35 or greater, there was a 14.5-fold risk in cardiometabolic multimorbidity compared to those with healthy weight.
That's a big difference, Mike. I'm glad you brought up BMI because I think it's important to recognize that BMI is limited in determining body composition or even measuring obesity. It does not measure body fat distribution or dysfunction of body fat. It does not consider individuality of each patient regarding their background or social determinants of health. However, at least from a population standpoint, BMI is a very valuable screening tool for increased risk of various complications and comorbidities. Having said that, Mike, can you talk to us a little bit more about BMI and these categories that you just mentioned?
Sure, happy to. I think it's important to point out that obesity is not a binary disease, meaning it's not a matter of whether you have it or not. But rather, within obesity, there is a spectrum of the severity of the disease. And as you said, even though by itself, BMI is not the most accurate tool to measure obesity or fat mass, when combined with clinical evaluation, it can be a helpful measure used to aid in the diagnosis and categorization of obesity severity. A person with a BMI of 18.5 to less than 25 falls in the normal weight category. BMI of 25 to less than 30 is considered overweight, and 30 or greater is considered obesity. And within the obesity category, we see gradations in the severity of the disease. BMI of 35 to less than 40 is defined as severe or class 2 obesity, and BMI of 40 and above is considered class 3 obesity, which is a gradually increasing obesity category. I encourage all clinicians to document the severity of obesity of their patients and to think of obesity as a spectrum, just as we consider other risk factors like cholesterol, hypertension, and even diabetes as a spectrum. An increasing BMI is associated with increasing cardiovascular risk across the entire spectrum of obesity, similar to what we talked about regarding cardiometabolic multimorbidity risk.
And I'd like to add that we need to be aware that a BMI of 30 implies that there is a cut point where you have a disease or you don't. But that cut point can actually vary depending on the population. So for instance, in Asian populations, that cut point is actually lower, bringing up the whole point that a genetic predisposition for abnormal fat or fat dysfunction and the need to look at the individual as a whole. And with obesity being such a significant modifiable risk factor for cardiovascular disease, as a cardiologist, what proportion of your patient population would you say has obesity?
In my prevention clinic, my preventive cardiology clinic, I would say about 2/3 of my patients have obesity, and probably 1/3 of those have severe obesity with at least class 2 or class 3 obesity. Now, in my cardiometabolic clinic, we have even more patients with obesity since we're taking referrals for patients at very high cardiometabolic risk. I'd say 50% of our referrals have a BMI of 35 or greater in that clinic.
And what if you include those with overweight?
If we include patients with overweight, I would say that 80% of my patients have either overweight or varying grades of obesity. That's a high number, but it's really not surprising to me because amongst cardiometabolic diseases, cardiovascular disease is the number one cause of death for people with obesity. In fact, the Global Burden of Disease study, which included 68.5 million people from 195 countries, conducted over 25 years, from 1990 to 2015, found that more than 2/3 of deaths related to overweight or obesity were due to cardiovascular disease.
So, what types of cardiovascular disease are associated with obesity?
Yeah, obesity has been associated with a greater adjusted incidence of cardiovascular events across many cardiovascular disease subtypes, such as coronary heart disease, stroke, and heart failure. Obesity is also associated with many more subtypes of cardiovascular disease that we see every day in clinic, such as cardiomyopathies, peripheral arterial disease, and arrhythmias, in particular, atrial fibrillation and atrial flutter, and deep venous thrombosis, pulmonary embolism, and aortic disease as well. In my practice, I'd say about 50% of my referrals have obesity and established cardiovascular disease at the time of referral. The most common referral for patients with overweight and obesity would be a patient who has multiple cardiovascular risk factors, including high blood pressure and perhaps dyslipidemia. And they would also have an early cardiomyopathy, perhaps with diastolic dysfunction and emerging heart failure, and commonly have paroxysmal atrial fibrillation. I want to point out that I think it's very important to spend a little time with that patient, talking to them about how there may be a link between their obesity and their cardiovascular conditions. Because I think not only do we as healthcare professionals need to understand it, of course, but we need to communicate this link to our patients so they get it too. How about in your practice, Bob?
Well, in my practice, I think that most common presentation when someone comes in with obesity is concurrent hypertension. They may also have peripheral edema, which may be caused by peripheral venous disease. Someone with obesity may come in with shortness of breath, which may be due to congestive heart failure. We need to remember that obesity through multiple pathways can contribute to the development of cardiovascular diseases. But we have to be careful not to ascribe those types of symptoms solely to obesity itself, but rather to a complication of obesity or comorbidity. Okay, so we've established that people with obesity have an increased risk for cardiovascular disease. Now let's talk about how obesity can increase cardiovascular risk. Healthy adipose tissue is made up of smaller, normal functioning adipocytes. The interplay between genetic, environmental, and physiologic factors that we talked about before can contribute to a positive caloric balance, which eventually can lead to an accumulation and hypertrophy of fat cells, making them prone to infiltration of pro-inflammatory cells, which subsequently release large amounts of pro-inflammatory cytokines and adipokines. At this point, adipose tissue is dysfunctional, some call it sick fat, which in turn creates a state of low-grade chronic inflammation throughout the body and promotes oxidative stress, which is accompanied by lower antioxidant defenses. Both chronic inflammation and oxidative stress contribute to the pathophysiological processes that occur in the development of obesity-related comorbidities. Dysfunctional fat and the release of adipokines lead to systemic inflammation, which then affect multiple organs, including the heart, muscles, the liver, and even the pancreas, and contributes to various complications. Metabolic dysfunction and lowering of high-density lipoprotein or HDL cholesterol and an increase in atherosclerotic low-density lipoprotein, LDL cholesterol, can lead to increased glucose, increased blood pressure, and general inflammation. Insulin resistance leads to ectopic fat deposition in multiple organs, which further impairs the function of the organ, leading to overall metabolic distress and contributing to plaque formation and development of cardiovascular disease. The underlying oxidative stress also damages endothelial cells, increasing their permeability and facilitating plaque deposition and decreasing the ability of blood vessels to dilate, further contributing to the development of hypertension. So as we can see, these weight-related comorbidities, type 2 diabetes, insulin resistance, hypertension, dyslipidemia, all of which contribute to the development of atherosclerosis, all have underlying chronic systemic inflammation and oxidative stress. In other words, obesity is a direct and indirect contributor to cardiovascular disease by affecting blood pressure and causing abnormal lipid levels, such as high triglycerides and low HDL cholesterol, for example. Obesity indirectly drives cardiovascular risk. But even in the absence of these markers, obesity-induced inflammation could put patients at direct risk for cardiovascular disease. Now that we've discussed how obesity can contribute to cardiovascular disease, let's talk about whether standard of care for cardiovascular disease is enough to address this increased risk for a recurring cardiovascular event in a patient with obesity.
What you're getting at is cardiovascular residual risk, which is such an important concept and something that we talk about in cardiology practice literally every day. Residual cardiovascular risk is the risk for cardiovascular events that still remains even after patients are treated with cardiovascular standard of care for their traditional risk factors like hypertension. That patient still has residual cardiovascular risk that must be addressed in clinical practice. This concept of residual risk was illustrated in a prospective study of serial carotid magnetic resonance imaging conducted in 106 adults with hyperlipidemia with a BMI ranging from less than 25 to less than 30 or overweight, or 30 or greater, the obesity group. Following treatment with optimal statin therapy, patients with obesity actually achieved significantly greater LDL reduction compared to those without obesity, yet even still, patients with obesity had significantly greater progression of carotid atherosclerosis compared to those without obesity. So despite being on optimal statin therapy and having greater reduction in LDL, patients with obesity still had greater cardiovascular risk compared to those without obesity.
So, Mike, what does that mean to you?
Yeah, it means that for people with obesity, many of whom, as we've said, have a history of CVD, addressing cardiovascular risk with standard of care may not be enough. We need to reduce the cardiovascular risk in any and every way we can. And this really is a call to action for cardiologists to think about obesity in their patients and take ownership of obesity as a chronic disease that increases the risk of most of the cardiovascular diseases that we see in clinical practice. For example, a patient comes in with overweight or obesity and cardiovascular disease. We need to take a holistic view of the patient and make sure that all aspects of their disease are addressed. And this means not only the weight, but also the increased risk of recurrent events that these patients have. We need to address the residual cardiovascular risk in any and all ways that we can.
I agree. I want to mention that what I've noticed is that patients often focus on specific targets, such as control of blood pressure, LDL cholesterol, or blood sugar, and that they're doing everything they can. If they also lost some weight, that would probably help as well. But the weight is almost something that's brought up when they're leaving the office, when their hands are on the doorknob. But we need to make it clear to patients and all healthcare professionals that obesity needs to be thought of as a risk factor right up front, along with cardiovascular risk reduction. Mike, as we close this podcast, based on our discussion today, what is your call to action to your fellow cardiologists?
Yeah, thanks. What I would encourage cardiologists and all healthcare professionals to do is to take an active role in addressing the increased cardiovascular risk in patients with obesity. Think of obesity as being central to residual cardiovascular risk in many of the patients that we see. Once you've controlled their blood pressure and their LDL cholesterol, for example, much of the residual risk may be attributable to obesity. And we can't get overly distracted by these individual risk factors. When I talk to my patients with obesity and cardiovascular disease, I explain to them how obesity is a significant contributing factor in the development and progression of cardiovascular disease. I tell them about how obesity is driving their blood pressure and contributing to the emerging heart failure and is a factor that increases their risk of developing atrial fibrillation. So it's worth spending a few extra minutes with that patient talking about this and the importance of a comprehensive weight management approach. And if the patient left the clinic without understanding that obesity is a major risk factor for cardiovascular disease, then that would have been a failed visit, I think.
Mike, thank you so much for a great discussion. This concludes the episode of A Story of Two Diseases, Obesity and CVD. Please join us for the next episode of Obesity Chronicles, A Novel Perspective. For more information, please visit rethinkobesity.com.